Hello, and thank you for joining us for this training on screening for substance use and depression, a booster training. So most of you all will have already received our initial introductory training here within the ED on screening for substance use and depression. Today's training is meant to just be a little bit of a booster and update to help reinforce some of those key concepts and effective screening strategies for you. So we'll review those key concepts, also the screening strategies, and then we will conclude by you'll have an opportunity to see a few role play demonstrations of effective screening. So as a reminder, screening, brief intervention, and referral to treatment, or SBIRT, as it's known in brief, is an evidence-based framework for the early identification and intervention of behavioral health problems. Now, the reason that we assess for behavioral health problems within medical settings such as the ED is because of the incredibly high comorbidity or co-occurrence of mental health with physical health ailments. Many people across the nation medical providers are starting to experience the strain of needing to respond to and treat to behavioral health conditions above and beyond medical conditions. And what the research does show us is that folks who are experiencing medical health conditions have a harder time managing their health and maintaining their treatment plans when there is a presence of an existing co-occurring mental health or substance use condition. So just to show you some data on this, looking at Medicaid patients who are experiencing some of the top 5 health conditions that contribute to repeat visits: hypertension, diabetes, coronary heart disease, congestive heart failure, and COPD or asthma. And what they did was they looked to see what percentage of these patients experience no co-occurring mental health or substance use concerns and which do. And really about a quarter to a third of the patients experience no comorbidity, which is actually a really small percentage compared to the majority. The majority experienced some sort of mental health diagnosis. This was most often depression. A substance use disorder diagnosis, and what we know about substance use disorder diagnoses is it tends to co-occur with mental health conditions. And so you see about another 10 to 20% experiencing those. So what we know about these patients is not only do those with more complexity tend to come back to the hospital and come back to EDs more frequently, they also cost the system a lot more money. And most importantly, it's harder for them to manage their health because they've got these competing demands of their mental health as well as substance use related issues. So another reason why we're interested in this is I know a number of you all have also experienced and seen firsthand in the patients in the ED the rise in the opioid crisis in the Winchester and surrounding areas. So this is a growing concern nationwide. It seems to hit certain areas of the state more so than others, with your area being one of those targeted areas. And so what we can see here is some statistics that show across various counties in the state. So we've got Clark, Frederick, and Winchester County, Loudoun County, Fairfax County, and Fairfax City, as well as the state of Virginia. And you can see the percent increase in heroin and opioid deaths from 2010 to 2013, and seeing that stark increase there for Clark, Frederick, and Winchester County compared to some of the other areas of the state. All the state is experiencing pretty significant increases. Now, if you compare that to population growth within these different counties, what we're seeing here is it's not that more people are moving into this area, but the existing community is starting to experience more of these problems related to heroin and opioid, and ultimately resulting in opioid deaths. Some additional statistics about what we're seeing at Winchester Medical Center in terms of opioid and heroin cases. You can see that between 2012 to 2016, a number of the inpatient visits related to opioid and heroin cases. And then you also will see that there's a growing increase there in terms of the ED visits. And I know this has been echoed by some of you all in our initial trainings as well. A common health problem related to opioid misuse, endocarditis. You can see here over time between 2012 to 2016 the increase in patients who are experiencing that condition. Another complication of opioid misuse in pregnancy is neonatal abstinence syndrome. What you can see here is over time we are seeing that steady increase. So we're seeing not only the steady increase in terms of opioid related conditions bringing people into the ED, but greater percentages of overdose, successful overdose, as well as unsuccessful overdose, as well as the complications related to opioid misuse. So endocarditis and neonatal abstinence syndrome being some of those. What you see here in the squares within the bars is showing for neonatal abstinence syndrome babies, the typical length of stay within the hospital after they are born. They tend to have a number of birth-related conditions and defects, as well as higher needs, given that they are born addicted to the substance and they start their lives off in withdrawal. So all of this speaks to sort of why we want to do screening for substance use and mental health concerns. Not to mention that about 50 to 60% of the accidents and injuries that land people in the ED are often secondary relatedly to some sort of substance misuse. So there's great reason to start to attend to this so that we can actually have successful conversations with patients in ways that we try to shift their trajectory of use in a way that lowers their risk for those repeat visits and injuries, and also lowers their risk for the development of substance use disorder or addiction. So how do we approach screening? Well, I think it's important to think about the rationale for universal screening as opposed to selective screening. Oftentimes, about 90% of the times, the national data shows us that substance use disorders go undetected. There's no good look test to determine who's going to be at risk for substance use or mental health related concerns. So universal screening really is the process of screening every single patient with a particular screening tool, such as a blood pressure test or a question around tobacco use. In this case, it's questions around substance use and mood or depression. And by doing this for everybody, it not only it normalizes the process, it destigmatizes these areas as areas of concern, and it allows us to identify folks who otherwise may not have gone identified. So some of the things that help provide the rationale is the commonness of drinking and drug use, especially in the ED setting, the fact that they tend to go undetected, and the fact that a lot of people are pretty open to change, more than people would expect, just by starting to have these conversations around their levels of risk related to their use. So whenever we do screening, it's imperative that we use validated screening tools. And what I mean by validated screening tools, these are instruments that have been psychometrically tested to show to be able to produce consistent results or be reliable, to truly measure what they're trying to measure, which is a measure of validity, and also being able to accurately identify the presence of a particular condition, which is sensitivity. And the screening tools that we use, we'll go through them one by one, and the first one is screening for alcohol use. The validated screening tool that is used is the US version of the Alcohol Use Disorder Identification Test, also known as the US Audit. And there are 3 universal or triage questions that are asked by the ED staff nurses in triage when we're screening for alcohol use. It is important to keep in mind, however, a couple of things as it relates to screening for alcohol use. First is the dosing of alcohol. Just like we want to have a clear understanding of what dose somebody's taking of a particular medication, it's also imperative that we are on the same page with our patients in terms of what we mean when we're talking about a drink. Because the questions do ask, in thinking about your drinking over the past year, and by drinking, you provide them education as to what is considered a standard drink. So one person's drink may not be the equivalent of somebody else's drink. And so it's really important to make sure that we are on the same page for what those standard drinks are. Not only that, it's important to keep in mind that there may be groups and communities and cultural subgroups for whom, when we ask about alcohol, may not identify particular alcohol types as alcohol. Some folks, for instance, may not, or cultures may not consider beer alcohol. When you initially say alcohol, liquor may go to mind or something like that. So it's important to have a good understanding of the types of drinking that is done in the area, your community that you're serving, as well as size of drinks that are common, so that we can all be on the same page. So what is a standard drink? A standard drink is defined as about a 5-ounce glass of wine, which is the equivalent to about 1.5 ounces of spirits, which is equivalent to a 12-ounce glass of regular beer. I say regular beer to differentiate it from craft beers, which are growing in popularity but also in alcohol content. So it's often closer to 8 to 9 ounces of a craft beer, because one full 12-ounce craft beer may be more closely to the equivalent of somewhere between, around 1.5, oftentimes, alcohol content to a regular beer. The alcohol drinking limits are used to determine if somebody is going to be identified as risk positive on a screening instrument. And so these are put out by NIAAA, which is the National Institute for Alcohol Abuse and Alcoholism, and also mimic some of the medical recommendations. This originally came out by the American Diabetes Association. And that says that for healthy men, the recommended limit is no more than 4 drinks in a day or 14 in a week. And for healthy women, it's no more than 3 in a day or no more than 7 in a week. Now, for folks who are over 65, that could be men or women over the age of 65, those limits stick with no more than 3 in a day or 7 in a week. For pregnant women, 0 for 9 is still considered the recommended level of use, which is no use for the full 9 months. Now, getting to the actual screening questions for alcohol, there are 3. You'll notice that all the screening questions start with an introductory statement. It is critical to read that introductory statement to the patient because they serve important purposes. For all the questions, they provide a time frame for the level of use that you're trying to assess. And then, at least in the case of the alcohol, it also provides that clarification as to what is a standard drink. So in this case, the introduction being thinking about your drinking in the past year. A drink means 1 beer, 1 small glass of wine, 5 ounces, or 1 mixed drink containing 1 shot, 1.5 ounces of spirits. And then you would go into the first question. How often do you have a drink containing alcohol? If somebody answers never, then they're done. They don't answer any additional questions. If they do answer positively, you would determine the appropriate time frame based on their response, and you would continue on with the next 2 questions. The next question tries to get a better sense of their overall frequency of use. So how many drinks containing alcohol do you have on a typical day you're drinking? And then lastly, we're trying to get at episodes of binge drinking consumption. So how often have you had either 5 or 4 or more drinks on one occasion? And that question is differentiated again based on whether somebody is male, female, or over under the age of 65. In general, if somebody's drinking above the recommended guidelines on alcohol, they would be considered risk positive for alcohol use. Now, in addition to screening for alcohol use, we also screen for drug use. The validated tool is the drug abuse screening test, and there are 4 universal or triage questions that are asked related to drug use. The first asks how often in the past year they've used marijuana or cannabis. I want to mention a couple things about this. One, it's separated out intentionally from the other drug categories, as many people don't classify it or count it as a drug. Hence, it's helpful to ask about it separately so that we can actually capture if that is in fact something that's being used. Second, you may have a patient who comes in who's a resident of an area where they have access to medical marijuana, and they do have a prescription. If somebody has a prescription and they're using according to their prescription, then we would indicate that there's no level of risk. So they would get a score of never if they're using their marijuana as part of a prescription. In contrast, if somebody's using marijuana to treat a medical condition or for recreational use, and they don't have a prescription, or they're doubling up on their prescription, then that would be considered risky level of use, and then we would still score it based on the overall frequency of use. The next two questions ask about prescription medication misuse. And what we're really interested here is how often they are using prescriptions that weren't prescribed to them, say they got them from a friend, a family member off the street, and how often they're using their own prescriptions, but they're using them more than what they're supposed to be using them, or for reasons other than intended, like the feeling to feel high, things like that. We're primarily interested with use of controlled substances here, things like benzodiazepines, sleep aids, opioids, stimulants, and but that is not your determination that you need to make at this point. We ask the question at the point of screening, and then the SBIRT clinician who might be coming in for consult later would follow up with them on specifically what their use is around. And then finally, there's a question on other sort of drugs, your other sort of general drug categories. For the drug screening, any endorsement of a positive use on any of the items is going to yield a positive universal drug screen. We also screen for tobacco use. This is just one single question. Again, there's where it's critical to utilize the introductory statement. Here you notice that rather than screening for the past year's use, we're actually asking about the past month. So in the past month, how often have you used tobacco products? And this is meant to get both smoking and non-smoking or smokeless tobacco products such as e-cigarettes are all captured. Any level of use is considered a positive screen for tobacco. And lastly, we also screen for depression. We use one of the most widely used instruments in medical settings. Many of you may have been exposed to it in your training or in working in other clinics. It's the Patient Health Questionnaire 9-item version. And there are two questions on this. The first two questions that are used as the universal or triage questions. And again, you see the time frame is different for depression. We're looking at someone's mood in the past 2 weeks. And so the questions are asking over the past 2 weeks how often the patient's been bothered by little interest or pleasure in doing things, or feeling down, depressed, or hopeless. On this instrument, a score of 3 or more is going to put somebody in a risk positive range. Finally, during the time of grant funding, this project is receiving funds from the federal government to help support the implementation of this project. As a result, the federal government does have requirements that we ask patients who are receiving SBIRT services certain demographic questions. Many of these we're able to pull directly out of the EHR in terms of the demographics that have been provided at registration and are in the patient's medical record. There are a few, however, that are not in there, and so we have added them in. And so after asking the questions around mood, there are a few demographic questions to ask. First is, what is your gender? Again, it's important to ask this question, even if it seems obvious to you. There's no look test for how somebody identifies in terms of their gender. So we want to respect that and not make any assumptions. So we ask every person what their gender is. We also ask, there's a question on whether or not the patient is Hispanic or Latino, and if so, what specific ethnic group do they consider themselves? In other words, from what region or area do they consider themselves to be from? Finally, the federal government's interested in what types of military service history experiences patients who are receiving various federally funded programs have experienced. So there's a question about having served, as well as whether or not someone's currently on active duty and whether they've ever been deployed to a combat zone. So now that we've talked about what this screening looks like, I want to talk a little bit about the strategies for a successful screening. So there's a couple of them. The first is an introduction to the questions. In general, it's helpful for patients to have an idea of why we're asking them certain questions. So a sample is script to kind of help segue as you enter into the SBIRT portion of the triage might be, we ask all of our patients about behaviors that increase risk for accidents, injuries, and other conditions that bring people into the ED. I'd like to start by asking you a few questions about your alcohol use, and then you could sort of go straight into those alcohol triage questions. People may ask questions of you. Why are you asking these questions? Then they may ask that for a couple of reasons. They may have concerns about confidentiality. They may notice that it's different, that you've never asked them these questions before. Maybe they frequently come to the ED. And easy responses to those are, this is sort of a new program we're implementing where we're trying to screen more widely around health and wellness and risks that often land people in the ED. And also just want to assure you that all the information you give us is completely confidential, just as the rest of your medical information is. It can be helpful to have transitions between question sets. So after somebody, answers the questions around alcohol, you may say, okay, now I'd like to ask you a little bit about your drug use. Now I'd like to ask you about your use of tobacco. Lastly, I'd like to ask you about your mood. And also having memory anchors for various time points. When we're asking about alcohol and drugs, we're asking about use in the past year. When we're asking about tobacco use, we're asking about the past month. When we ask about depression, we're asking about the past 2 weeks. Keeping in mind that patients may or may not hold that time point in their mind, especially if they're under any sort of duress while they're there, which many of them are going to be. So it's helpful to also build in a memory anchor. So I'd like you to think about your drinking in the past year. So that would be since January 19th, 2016. So this time last year, all the way up through today. And then you can sort of proceed with the script and the remaining questions. That sort of anchor point can really help keep people on track so that you're assessing use in the past year. There are going to be situations that come up where maybe someone's had pretty dramatic changes to their use over the past year. Say perhaps they were using, drugs heavily for the first 3 months of the year and then haven't for the remaining months since. And in those cases, you would just assess based on their highest level of use when they were using. The SBIRT clinician would still come in, and that conversation would be a little bit more about how to help them continue towards their path that they're currently on. We know the risk of relapse is high, so it's often helpful to have those conversations, even if somebody has made a significant change to their use already, to see if they might need some additional resources to help them continue to be successful. These are validated screening tools, so that means it's important that every person who gets them delivered in the same way. So that's why it's important to stick to the questions as worded. And you don't need to provide response options for every single question that you ask. More often than not, the patient's response will help you determine how to best rate that. If there's any ambiguity, you can ask for a clarification. So would you say that's more close to monthly or weekly for you? And the other thing is keeping in mind that we want to be non-judgmental and empathic both in how we ask the questions as well as our nonverbal behaviors during screening. As you become more comfortable with the questions, you'll be able to ask the questions while keeping more eye contact with the patient. Doing things that are verbally nodding is okay. We want to be careful of any sort of negativity or bias or judgment coming from us in our voices or in our nonverbal behaviors that may that may make the patient feel uncomfortable. There are a couple of times when we do not screen. We do not screen for SBIRT in particular for minors, so patients who are under 18, as well as a few acute conditions. So if someone's experiencing acute medical, psychiatric conditions or acute intoxication or being high to the point where they're not able to clearly communicate, those are times where we wouldn't come in and do screening. And then there may be some other acute sessions based on nurse judgment that you determine to not screen. So after you do a screening, and it is a positive screening, you would be reaching out to the SBIRT clinician, and we'll talk about the specific steps in a moment. But some of the concerns, you may have concerns that you want to communicate to the clinician about their appropriateness for either doing the screen or for the clinician to come and follow up if you have done the screen. And some of those things to consider would be current pain level of consciousness, their affect or mood of the moment, and any other sort of behaviors of concern or being under the influence. Typically, SBIRT clinicians will not do a secondary screening on someone who is actively intoxicated at the level where they're not able to really sort of communicate well, or somebody's in current suicidal or homicidal crisis. However, they do still reach out to those who may be intoxicated. They may leave resources, follow up at a later time with them. So your role in responding to positive and negative screens. For negative screens, it can be healthy to reinforce healthy decision making. So somebody is using alcohol, but they are using it within the recommended guidelines, so they didn't trigger as risk positive. Just a quick statement before you transition to drug use could be, well, it sounds like you're, using alcohol in a way that's responsible and keeping your risk low for health issues. That's great. Now I'd like to ask you a few questions about your drug use. So it can be, a lot of times people don't get the opportunity to get positive feedback on the things that they're doing well to manage their health. And this is a critical opportunity where you're able to provide that. When there's a positive screen, you'll know it's a positive screen because you've got them in your handouts. We'll see them momentarily. In EPIC, there is sort of a little scoring guide above each question set that lets you know what is considered a positive score. So if there is a positive, the steps include placing an order for the SBIRT consult, and this happens during SBIRT hours, documenting in the chart the notification of the SBIRT clinician so that it shows up in your tracking board view, calling the SBIRT office at 65191. When you call the office, this is your opportunity to give the clinician the patient's room, what they're positive for, and whether it would be a good time or when would be a good time for them to come see the patient. This is when you might also share any other sort of concerns that you have in terms of erratic behavior, intoxication, or other things. If no one answers, leave a message, because messages are always followed up with during shift whenever someone's on shift, and after hours are always followed up the next day by the lead clinician. If no clinician is on site or you're screening outside of SBIRT hours, the protocol is to give the patient a brochure, one of the SBIRT brochures. You can let them know to expect a follow-up. And for the SBIRT clinician, once the consult is complete, they will check in with you to communicate any relevant information to the patient's care and mark the order as complete in the navigator, as well as write a note in the patient's chart. So what does the SBIRT clinician do? They'll come in and they introduce themselves. So you really don't need to tell your patient about an SBIRT clinician coming in. They come in and they do a self-introduction. They do some additional screening to finish those validated screening tools so that they can determine the level of risk, mild, moderate, or severe. That level of risk determines what level of intervention a person needs. That brief intervention that they'll receive that day is going to be 5 to 15 minutes, and that focuses on getting them activated towards making sort of change to their level of use or their behavior. And for those who are in higher risk categories, it is working with them to get them connected to the appropriate treatment resources if they're open and interested in moving forward with treatment at the time. That may be treatment to one of the SBIRT clinicians on site for outpatient counseling, or it may be referring to an outside provider for a higher level of care. For tobacco, they'll don't do a secondary screening, but they do a brief intervention and work to see whether or not someone's interested in a referral for the Quit Now program. So why do we do SBIRT? Well, we started with some startling statistics as to what's going on in terms of your county, in your area with opioids, but also what's going on for people with chronic medical conditions, many of who land in the ED. And so given those high comorbidities, it makes sense to have a framework in place that is evidence-based that helps address the issue. And SBIRT not only is simple and brief, but it's been shown to be quite effective at helping reduce levels of use, reduce consequences associated with abuse, and also reducing risky behaviors. If you think about doing that brief intervention, that 5 to 15 minute conversation after screening, when you look at just the sort of people who fall in that mild and moderate risk category, so we're taking out the people who are in the high level of possibly addiction, substance use disorder diagnosis, you can see some pretty strong reductions in injuries, crashes, ED visits, hospital admissions, and arrests, just as a result of this fairly brief intervention. And it's also pretty significant cost savings as well for healthcare settings. So this is why we do SBIRT, how we do SBIRT, and a few strategies for successful screening. This just quickly want to show you, and I don't know if you'll be able to see it well in the slides behind me, however, you do have the handouts before you. This is just a quick screenshot that shows you what that triage section looks like. Most of you all are going to be familiar with that already if you've already been on the floor and doing this. And you can see on the very top in blue text that's sort of the scoring guide that tells you whether or not somebody is risk positive. The only other thing I want to highlight here as it relates to alcohol is you get to determine based on the patient's sex as well as their age which of the categories that you're going to use for screening them for alcohol. Because the risk levels do vary by age and sex, that we've sort of simpled it out for you by having different sort of question sets available. Then of course is just a screenshot for the drug use, tobacco, and depression, as well as the demographics. So we thank you for your attention, and we will be following up shortly with a couple of role play demonstrations to show both effective and not so effective screening for substance use and mood concerns. Thank you.